Good morning. Thank you for the invitation to speak. I appreciate it. It's great to see so many faces that I recognize out in the audience. So today I'm going to talk about seizures in the ICU. I have 30 minutes to talk about what I've been doing for 20 years. So I will, first of all, I want to say I don't have any relationships to industry. And also the most important thing is this is a talk about adults, and kids are not little adults. And so this doesn't apply to children. So please keep that in mind when we're discussing today. So our landmarks for today, or our roadmap, if you will, we're going to just briefly talk about some updated terminology that I'll be using during the test or during the talk. We're going to talk about continuous EEG monitoring, how we pick which patients to monitor. We're going to talk about status epilepticus and the treatment and the etiology of status epilepticus. Talk about when to de-escalate care. Talk a little bit about anoxic patients and EEG findings, and then we'll end with seizure prophylaxis. So I can't see far away very well, and I don't have my glasses. So I'm going to be probably turning my head because I can't see my slides up there very well. Okay, so updated terminology, and this is what we need to be using when we're talking about seizures, when we're documenting seizures. International League Against Epilepsy is really trying to streamline what we talk about to make it more descriptive, what we actually see. So we no longer use the term anti-epileptic drug, we use the term anti-seizure medication. And the reason for that is, the main reason is these are not medications that do anything to modify epilepsy, they stop seizures. Secondly, AED is a very common acronym that the layperson knows for the automated external defibrillator, so we're not going to take that away from them. So now we use the term anti-seizure medication. Which used to be called simple when we're talking about seizures, where people maintain awareness. And we used to call complex, where they lose awareness. And a partial seizure is now called a focal seizure, meaning it's coming from one area of the brain. So a partial complex seizure is now called a focal seizure with loss of awareness. So you know much clearer it's coming from one area of the brain, and there is loss of awareness with the seizure. And so again, just trying to make our terms more descriptive and more easier to understand. So just a little baseline from where we're going to go. Okay, so the first thing I would like to talk about is how we pick which patients need a continuous EEG. So continuous EEG is one that is on the patient overnight, usually for several hours. It's quite labor intensive in terms of the technicians, hooking up the patients, technicians monitoring the patients the overnight, and then the neurologists that have to read the studies, which takes sometimes, if they're difficult to read, up to an hour. And if you have 4 or 5 patients on continuous EEG, that's going to be half of your morning. And so there has been a score that has been developed, the 2 Helps 2B score, that was published in the Annals of Neurology, validated a couple years later. And what this does is it says, which of our patients need a continuous EEG? Based on 6 things. 5 of them are which are EEG findings. This is not a talk about EEG, don't worry. But all of these acronyms you see are all EEG findings, except for one thing, which you'll see the 5th one down, histories of seizures, either right now or in the past. So we hook up an EEG for the patient. It runs for about an hour. The neurophysiologist, the epileptologist reads the EEG, and based on the findings, we determine, do they need a continuous EEG or not? And so you get 1 point for every one of those, except for one, which I'll show you in a second, which is 2 points where you're having epileptic activity. And if you score 2 or higher, your risk of having a seizure is about 27%. So then they recommend at least 24 hours of continuous monitoring if you have 2 points or higher. So basically what that means is, if you've had a seizure ever, and you have an abnormal finding on the EEG, then you're going to need a continuous monitoring for at least 24 hours. This finding is called BIRDS, which is brief ictal rhythmic discharges. This is in the left temporal lobe. And so it starts to have this is not technically a seizure. It's in the orange one in the middle. It's not technically a seizure because it doesn't last long enough. It has to last 10 seconds to be a seizure. But this is what gives you 2 points. If you see this on the continuous EEG, then, or excuse me, on the routine screening 1 hour, then you would hook them up for a continuous. This is something called generalized periodic discharges, or GPEDs, you may have heard it called. This is where you have the whole brain is having a misfiring about 1 second, a little less than 1 second. And so this finding here, with a history of seizures, you go ahead and hook the patient up. This is a very similar finding, except it's not over the whole head, it's just on one side, so we call it lateralized periodic discharges. And so this would also be a finding, again with a history of seizures, that would say, okay, let's go ahead and do a continuous EEG on this patient. And these are patients that are not awake and alert like we are talking to each other. These are patients with a lower GCS scale. Okay, so now let's shift gears. We're going to spend a lot of time talking about status epilepticus because that's what we see in the ICU. And so what is status epilepticus? Well, we have a failure of the mechanisms in the brain where the seizures are not stopping. And there's two different types of seizures. So the generalized tonic-clonic seizures lasting for more than 5 minutes, that's when we need to initiate emergency treatment. For a focal status epilepticus, with or without loss of consciousness, or absence seizures, we're not really talking about absence because that's more in kids, but then that time 1 where we need to start emergency treatment is 10 minutes. Probably more importantly is time 2, where we're going to start to see potentially some permanent neuronal damages, and that's when we've got to get the seizures to stop. So for generalized tonic-clonic seizures, that's 30 minutes, and for the focal seizures, that's 60 minutes. The American Epilepsy Society, along with other big organizations like the American Academy of Neurology, the Critical Care Society, has published guidelines of how we treat status epilepticus. And similar to stroke, where time is brain, it's very important that we work very quickly to get these seizures controlled. And oftentimes, these aren't happening in the ICU. These are happening out in the field. They're happening in the emergency room. But we'll go through each step and what we need to do to get these seizures to stop. So of course, 0 to 5 minutes, that's our stabilization phase. So the ABCs that we all know of: airway, breathing, circulation. We want to time the seizure, monitor their vitals, assess their airway, make sure they're breathing okay. If we need to intubate them, we need to initiate that. EKG monitoring. Of course, we want to check their glucose, and you give thiamine and glucose, always in adults. And then we want to try to get IV access, get the blood work going as quickly as we can. And for 5 minutes, if they're still seizing, then we start the treatment, the algorithm for the treatment of status epilepticus. And benzodiazepines are the first line therapy. It's level A evidence. And the first 3 are intramuscular midazolam, IV lorazepam, or IV diazepam. And most commonly here in the emergency rooms, we're using the IV lorazepam. And you can see here the doses. And we're going to focus on lorazepam because I want to make mention of the dose that you're supposed to use. It's 0.1 mg per kg up to 4 milligrams. You can repeat it once. And so most of these patients are going to need 4 milligrams of Ativan very quickly. And if they continue to seize for another few minutes, then you would do a second dose of the Ativan. If, for whatever reason, it's not available, phenobarbital has high level of evidence, level A, rectal diazepam and intranasal midazolam you can also give. And let me do a timeout real quick. So the patients with epilepsy, I'm an epileptologist, I have many patients with epilepsy, most of them have these rescue medications at home. A lot of adults don't have rectal diazepam anymore, but intranasal midazolam, intranasal diazepam are all options that my patients have. You can also do clonazepam. They have dissolvable clonazepam. They have films, dissolvable. I think that one's diazepam. But all of my patients have these medications that they can take at home to avoid going to the emergency room. Okay, so going back to status. So we've treated them with benzos. We've given them the full dose of benzos, and they're still seizing. Well, also, of course, we're working to make sure, okay, now we've given them 8 milligrams of Ativan. Are they breathing? Are they not? We're doing all these things, getting the labs back. So focusing just on the treatment, the next step is an anti-seizure medication. And they're the 3 that they recommend, and I believe it's level U evidence, which is kind of interesting, would be intravenous phosphenitoin, which for the purposes of this lecture is phenytoin, intravenous valproic acid, or intravenous levetiracetam. And each one of those, so the max of fosphenytoin is 1,500. It's weight-based dosing, but most people will probably get close to the max, which is 1,500 for fosphenytoin, 3,000 for valproic acid, and 4,500 for levetiracetam, which are really big doses. If those aren't available, phenobarbital is 15 mg per kg in a single dose. That's level B evidence, which is kind of interesting. It's a higher level of evidence than the other three. So which one do you pick? A New England Journal of Medicine trial looked at levetiracetam, fosphenytoin, valproic acid, and really didn't find any difference in the efficacy or the tolerability of the three. And then seizures were controlled in each one of those about 50% of the time, which still isn't actually that great. So that one showed the same. And then they've done a meta-analysis where they looked at those three plus another benzo, so diazepam, phenobarbital, lacosamide were added. Lacosamide is our newest medication, and it can be given IV. And when it looked at, the meta-analysis looked at all of them, the winner was actually phenobarbital. It was superior to all of them in stopping status epilepticus and no seizures at 24 hours. However, the valproic acid and lacosamide were best tolerated in terms of safety outcomes. Then, of course, we're not treating the seizures, we have to treat the patient, right? So what else is going on with the patient? Do they have cardiac history? Are they in renal failure? How does their liver work? What else is going on with the patient? So you have to think about those things. And very common side effect I listed, hypotension, cardiac arrhythmias, we have to think about with phenytoin and lacosamide especially, levetiracetam, if they're in renal failure or they're end-stage renal disease, you have to renally dose that medication. And so a lot of things to think about when you're picking which medication you want to use. The top three I have a star next to because you can get levels the same day. And how I practice as an epileptologist is I really like to know what the level of anti-seizure medication is when I'm treating somebody in status. Because if I give them a fosphenytoin load and their level is 10, then I know I have, when I'm adjusting the anti-seizure medicine, I know I can probably go up on the dosage. Same thing for valproic acid and phenobarbital. And then the bottom the bottom three need to be renally dosed. So of course we need to keep that in mind when we're picking which medication to use. And unfortunately, or fortunately, a lot of times they come to the ICU and they've been given 2 milligrams of Ativan and a gram of Keppra. So gram of levetiracetam. So that's underdosed. So we need to figure out how much they've been given and then optimize that before we escalate it to the next step. And the next step, if they continue to have seizures, despite the benzodiazepine, despite the anti-seizure medication, would be sedation. And unfortunately, there's not really good criteria, level U, from the American Epilepsy Society of which to use next. But the Neurocritical Care Society has recommended the midazolam or the propofol. I know we've all used this. And there they list the loading doses and the boluses and then where to run it at. And the goal of all of this, when we've escalated now to a sedating medication, is of course we're hooking them up to a continuous EEG and we want the seizures to stop. They may clinically stop seizing, meaning we don't see them having convulsions anymore, but they may not be waking up. And so we need to make sure that they're not waking up because they're not still seizing versus now getting all the sedating medications. And at the same time, we are thinking about why the heck did this person go into status? So sometimes it's easy. They come in as a trauma, or let me jump to the very bottom one, they have a history of epilepsy and they haven't taken their medicine. That's the #1 cause of people that have epilepsy that come in status. So if they are on Banzel, lamotrigine, and lacosamide, and you're like, I don't really care, we can't give those medicines anyway, please draw us anti-seizure medication level, because if all those come back very, very low, then we immediately know, okay, this person, for whatever reason, weren't taking their seizure medicines. So it's really important, even though they're not going to come back for a week, to go ahead and get those. Their epileptologist will love you for that, I promise. But we're getting labs, we're checking their alcohol, taking a tox screen, looking at metabolic issues, looking for infections. We scan their head, we're looking for strokes and bleeds and tumors, and we're doing all of this stuff as we're treating the status epilepticus, because these are the most common suspects, right, for seizures, especially. So we have brain injuries and then hypoxia, which we'll talk about in a couple minutes. So, given the benzo, given the anti-seizure medication, given the sedating medicine, and they're still seizing. 24 hours later, then we get into what we call super refractory status epilepticus. And so these patients are still continuing to seize. They might not have physical, like clinical seizures, but they're still seizing on their EEG. Then we get into the big dogs where there is absolutely no evidence or recommendations for what to use. So this is off-label, but we commonly use, I know if you guys have been in the ICU, you've seen patients on pentobarbital or ketamine. And that's, the purpose of these medications, and you can see the doses here that they recommend, again, this is off-label, is to get the patient into what we call burst suppression. And burst suppression is Control-Alt-Delete for the brain. We are resetting the brain, okay? The first half of this EEG is a suppression pattern. So not much brain activity. You see a little muscle, that's the little tiny things. And then all of a sudden, the patient starts to have activity. On the next slide, you can see maybe the burst, or actually the spike and wave pattern much better, especially, and it slows down, and then you go back to a suppression pattern. And so this is what we would like to do. We have a little bit of activity. If you have absolutely none and it's all suppressed, that's a little too deep for my comfort in terms of when we're trying to Control-Alt-Delete the brain. I like to see a little bit of burst activity. This is actually quite a long burst. The first, how this EEG is read, that burst probably lasts for about 3 seconds. And on the last page, it was about 3 seconds. So, but we want to Control-Alt-Delete the brain with a with either pentobarbital or ketamine. And then we're getting into what we call new onset refractory status epilepticus, or NORS. So NORS is when they have no history of seizures, they have no identifiable brain lesion we have seen. So this is not the subdural that comes in who's seizing all the time. This is, we don't know. This is IDK. Why are they seizing? Then it's NORS. Okay? And we have to really start to think about what is going on with this patient. So these patients need very extensive workups as best we can do. So making sure that we've really looked at all the infectious etiologies, sending serum for weird things, sending CSF, sending an meningitis encephalitis panel. We want to do autoimmune paraneoplastic, which probably is most common cause of NORS, unfortunately, because these are not the outcome of these isn't great. So we're looking at all these weird autoimmune diseases, encephalopathy and autoimmune panel, paraneoplastic panels, both in the serum and the CSF. And actually here at Christus Mother Francis, we have really good panels that we can send off to Mayo, but the problem is they don't come back for several days. And so we've got to continue to treat the patient. Neoplastic is also in the differential, so everything's coming back negative. We need to think about, okay, do we need to scan the rest of the body? Weird things, mammograms, CSF cytology, flow cytology, scrotal ultrasounds, things like that. We really got to find what's going on. Metabolic and toxic, you can't forget about those either, heavy metals, things like that. After 72 hours, if they're still seizing, and we'll pull them off the sedation, and we still see seizure activity, then you need to think about, okay, do we need to do IV steroids? Do we need to do IVIG, plasma exchange, things like that, treating these autoimmune disorders, paraneoplastic things, if nothing's coming back positive. These are our Hail Marys, if you will. Dr. Shoup and I always have conversations. She's the neurohospitalist in town. I don't know what I'm treating. You're like, yeah, we don't know what we're treating, but they're still seizing, and anti-seizure medications aren't working. So then, when do we stop all of this? And that's probably Dr. Premachandra. I think he approached me and this is like, I want you to talk about this. And this is the hardest thing, is when you've done all these things for the patient, you've given them all these medicines, they're on continuous EEG, at what point do we start to say, okay, let's take some of this away? So we start to wean sedation. And as we are weaning sedation, we're looking at the brain waves. And we want to make sure that we don't see continued distinct seizure activity. So like those birds that I showed you in the first slide, what we're going to see and what's expected to see is like those GPEDs, so periodic discharges or lateralized discharges. That's normal. That's part of what we call the ictal continuum. And we're going to wake up these patients, take the sedation off. And how I practice is that you cannot take an EEG off the patient while they're still sedated, because if you do and they don't wake up, you don't know, is it just because they're not waking up, because they haven't cleared all the sedation, because they haven't cleared pentobarbital that has a half-life of 100 years. It really doesn't, but it takes forever to get out of the system. So you have to de-escalate the sedation, wake the person up. If they're really clinically doing much better, that's great. It doesn't really matter what the EEG shows as long as they're not having, seizures, and then you stop the EEG. But I think there's a little bit of a misnomer that you have to stop the EEG first and then you win sedation. That's opposite. And then probably one of the most important things to me as an outpatient epileptologist is we have to have a plan for the anti-seizure medications, because they're probably going to be on, I don't know, 100 milligrams of Cerebex or Dilantin. They're probably going to be on 2 grams or 4 grams a day of levetiracetam. They're probably going to be on 2 grams of valproic acid. And then when you extubate them and they sit up and PT tries to work with them, they can't walk because they have these really, really high doses of anti-seizure medications, which were needed to stop the seizures, but probably aren't going to be needed forever or for a long time. And we want these people to recover. We want these people to go to rehab and be able to walk again and get, their life back. And so the neurologist needs to have a good plan for, okay, this is how we're going to wean the medicines over the next weeks as they're going to rehab coming home. And then they need to have very close follow-up. This is kind of a soapbox thing of mine, especially as an epileptologist, with their seizure doctor or their neurologist. As soon as they get out of rehab, they need to see them, because we need to say, how are you doing? Are you dizzy when you stand up? Do you still have blurred vision? Are you able to participate in rehab? Are you sleepy all the time? Because if you are and you're not having seizures, let's start to de-escalate some of those anti-seizure medications. And most of my patients, this is anecdotal, probably 80% of them, maybe even 90, are not going to be on all of those anti-seizure medications that we initially stopped. We're going to be able to tailor them down. So it's important to have a good plan for that. Okay, switching gears. This is seizures or abnormal EEGs after cardiopulmonary arrest. So this is completely different than status epilepticus and very difficult to treat. And the American Heart Association, bless their heart, gave us guidelines that are not very good, unfortunately, because they're not very specific. So they said, well, we recommend treatment of seizures if they have them after cardiac arrest. So these are patients that have cardiac arrest, and then we have retained spontaneous circulation, okay? So their GCS score is low, they're not waking up, and we're trying to figure out what the next steps are. So they say also, you should probably get an EEG. That's the second one. The second one is, it could probably be a continuous EEG. That's probably a good idea. The next one is, you should probably treat the non-convulsive seizures if you see them on EEG. That's reasonable. And they use the term reasonable. You should try, the top one is a non-sedating anti-seizure medicine. Yes, that's reasonable. And the same anti-seizure medicines we use for seizures caused by other etiologies, you can use those for this. And so the only probably really hard evidence thing they say is these patients don't need seizure prophylaxis. Seizure prophylaxis is, I'm giving you seizure medicines and you've never had a seizure before. We're going to talk about that at the very end. But they say these patients with cardiac arrest, they don't need seizure prophylaxis. Thankfully, there was a study, Telstar study is what it was called, and it looked at patients that survived cardiac arrest and they had a low GCS, 9 or less. And they said they've got abnormal findings on their EEGs and maybe they've had seizures. That didn't really matter for this study if they had clinical seizures or not. And so we randomized them to 2 groups. One group got sedation, and one group got sedation and an anti-seizure medication. And the temperature management was the same, because a lot of times these patients are on the cooling protocol, so that was the same. And the primary outcome was, which group is going to do better? The ones that just got the sedation, or the ones that got the sedation and the anti-seizure medications? Meaning, do these anti-seizure medications work or not? And they also looked at mortality, these are secondary outcomes, length of stay in the ICU, and how long they were on the ventilator. And unfortunately, there was no difference. So the patients that got the anti-seizure medicine versus the ones that didn't, they all had basically poor outcome based on the scale that they used. 90% in the anti-seizure medication group and 92% in the other group. You can see in italics there the statistics. The secondary outcome, not very different either, and actually, unfortunately, quite poor. So in 3 months, 80% of the patients in the anti-seizure medication group, 82 in the other group, had passed away. The length of stay in the ICU was slightly longer for the anti-seizure medication group, as well as the length of ventilation. And this is probably one of the hardest things to treat in the ICU, is oftentimes these people come in, they've had a cardiac arrest. Length of downtime, unfortunately, is not a strong correlate, but of course, if they've been found down and you don't know, oftentimes they're having the myoclonic jerks, right? So these just non-rhythmic, just jerks. I know everyone probably have seen those. And then they have these abnormal findings on EEG. And the question that the ICU doctors always want to know, are these seizures? Can you get them to stop? And so they are seizures because the brain's irritated because it didn't get enough oxygen. But I don't know if I can get them to stop, because most likely we have a permanent anoxic injury. And this is just basically irritated brain. And as we go on the next couple days, what's going to happen is these, oftentimes they have like a burst suppression pattern, which will go to the GPED pattern, which will go to a slower pattern, and then just go to a suppression pattern on its own. If I give them anti-seizure medications after this and that all stops, then I know it was a seizure. But that's probably less than 5% of the time. And you certainly want to treat these patients and help the family if they're in there jerking all the time, right? We want to make everything look comfortable as we're deciding the prognosis of this patient and helping the family make decisions about what we're going to do next. So levetiracetam is a very good medication that helps with the myoclonic jerks, but as we can see in the Telstar study, it doesn't really affect long-term outcome. Benzodiazepines are also very good for myoclonus, but again, as we are seeing what's going to happen to the patient and we're weaning them from sedation, we want to make sure, we want to take that away. We don't want to have so much sedation on them because we're trying to make prognosis decisions. So basically, we don't know, but you got to treat the patient, right? Okay, and then lastly, seizure prophylaxis. So these patients have never had a seizure. Do we need to give them seizure medication? And there's actually really good data on all of these. And so traumatic brain injury, the answer is yes. And we have actually really specific guidelines. We give it for 7 days. Levetiracetam and phenytoin are about the same, but everybody loves levetiracetam, so they do that. And then you stop it after 7 days. Subdural hematoma, this is non-traumatic, so if it's a high risk, so their GCS score is low, they had delay surgery, or they're on anticoagulation beforehand, then usually, yes, you would give a short course of anti-seizure medication, but we don't really know how long. Most of the time, people use the same one for the traumatic brain injury for about 7 days. But we do know, and we have good data, that we do not do seizure prophylaxis in subarachnoid hemorrhage, intraparenchymal hemorrhage, non-traumatic, ischemic strokes, or brain tumors. So these patients do not need an anti-seizure medication unless they have had a seizure. Okay. And I did good with my timing. All right. Well, I appreciate, again, the opportunity to talk to you guys. I know it's break time, but I'm happy to take any questions if you have some. Yes? Oh, hold on. I think they want the microphone.
All right. You have someone in status on continuous.
Uh-huh.
Too close to the speaker. And you have them sedated.
Yes.
How long do you want to see absence of seizure activity before you wean sedation?
So that's a good question. There are no recommendations for that. But I personally, probably about 24 hours. Yes, before I start to wean sedation. Yes, but no good guidelines. Yeah. Any other questions?
How do you go about making the decision as to how long, you do the treatment for the epilepticus, the status?
So after the traumatic brain injury, how long do you treat the seizures? Is that your question? So has the patient had a seizure or not? Okay, so if they've had a seizure. Okay, so typically, and this is not necessarily just for traumatic brain injury, but it's also kind of in general for epilepsy, if you've been seizure-free for 2 years, then we consider coming off anti-seizure medication. You typically, though, will do an EEG before taking somebody off medicines. And if the EEG is normal, which in a traumatic brain injury patient, it may not be normal. But if the EEG is normal and they've been seizure-free for 2 years, the chances of having them seizure-free is actually pretty high. And you would just have a discussion with the patient. Okay, worst case scenario, if we take you off your medicines, you could have a seizure and blah, blah, blah. Or best case scenario, you don't go back and have a seizure. And it depends on the patient. Because some patients just really, really want to come off medicines, and some patients are very happy because they're doing well, not having seizures. Yep, good question.